Bismillah ar-Rahman ar-Rahim. This is Fatma Hamdi, Lecturer of Internal Medicine, Rheumatology and Immunology, Mansoura University. Today we will talk about approach to patients with joint pain, which is one of the complaints that commonly patients presents to the GP with. First of all, we have to talk about arthritis. What is arthritis? Arthritis is inflammation of the joint. This term is often used by public to indicate any disease involving pain or stiffness of the musculoskeletal system. So we should make sure from the patient that if his problem is related to real inflammation of the joints or the connective tissue, or it's just pain, not inflammation. At the start, we have to know what's the structure of the joint. The joint is an area of connection between two bones. As we can see in this image, we have two bony ends. Both bony ends are covered with the articular cartilage. This articular cartilage is very important, which protects the ends of the bone, and the cartilage also have the capability of regeneration. So if there is a minor trauma in the cartilage, can be regenerated. Okay. Also, we have the two bony ends are connected together by the ligaments, which protect the stability of the joint. Also, the cavity of the joint is lined with what's called the synovial membrane. The synovial membrane is secreting what's called the synovial fluid, which has a very important role in the lubrication of the joint movement that make the joint movement smooth. Now we will start with the approach to joint pain. When we have a patient with joint pain, how can we reach the diagnosis? We will start, of course, with the clinical evaluation. Then we will do some laboratory investigations and imaging for the patient. As regard the clinical evaluation, which is the most important item of evaluation of patients with joint pain, we will ask the patient 6 important questions. Whether the pain is articular or extra-articular, whether it's acute or chronic, whether it's inflammatory or non-inflammatory. Also, we want to ask about the number of joints involved, the distribution of joint involvement, and if there is any extra-articular manifestations. We will start by talking about whether the joint pain is articular or extra-articular. How can we differentiate between articular and extra-articular pain? If the pain and swelling, in case of articular joint, in case of articular musculoskeletal pain, the pain, swelling, and tenderness will be all over the joint line, and it will be more over the joint line. However, if it is non-articular, it will be localized to a certain point in the periarticular structure. Also, the articular pain is aggravated by both active and passive movement. However, non-articular is aggravated by the active movement only. What's the meaning of active and passive movement? The active movement is the movement which the patient is doing by his own muscles. So he is doing this movement actively. However, the passive movement, it's the movement which the physician is doing for the patient during the examination. So the patient is not doing it actively. So in case of articular joint pain, it will be both active and passive movement will aggravate the pain. However, in non-articular, it will be aggravated by the active movement, which is using the muscles and tendons and the structures related to the muscles. Also, in case of articular pain, we will find that the joint movement will be limited all over the range of movement. So if the joint is doing flexion, extension, internal rotation, and external rotation, abduction and adduction, so all these movements will be limited. However, if it is extra articular, there will be 1 or 2 planes which will be affected according to the structure affected. These photos represent examples of arthritis, articular involvement. We have here, you can find here there is swelling of the proximal interphalangeal joint of the hand. This is called PIP arthritis. Here also we can find that there is inflammation of all joints of the hand. This is the wrist joint, the MCBs, the PIPs, MCBs, which is the metacarpophalangeal joint, PIPs, proximal interphalangeal joint and distal interphalangeal joint. This image is for knee arthritis, and this image is for ankle arthritis. These images showing extra-articular pain. In this photo, we can find that this patient may come to complain that he has inflammation in his elbow. So I may think this is elbow arthritis. However, upon examination, I can find that all the inflammation and swelling is localized to the olecranon bursa. This is called olecranon bursitis. This is not related to elbow joint. Also in the next image, we can find that the inflammation here in the tendons of the first compartment of wrist. So the patient may think that he have a problem with his wrist joint, he having inflammation in his wrist joint, but this is not true. The problem is just in the tendons. So when I examine the patient hand, I will find that the tenderness will be localized to this side, to the lateral side of the wrist. Otherwise, the other parts of the wrist is clear. Also, the wrist movement will not be affected except in certain in the radial deviation. So this is called tendinitis, and this is extra-articular pain. Also, the patient having spasm in the calf muscles, he may think that this is related to the knee joint, but this is just spasm. Also, we have something which is very important, which is called the enthesitis. Enthesitis means inflammation at the sites of insertion or attachment of tendons or ligaments to the bone, and one of the most common sites is the Achilles tendon and attachment to the calcaneus. This can be found commonly with cases of spondyloarthropathy, and this is extra articular musculoskeletal involvement. All these are examples of extra articular pain. The second question, whether the musculoskeletal problem or the joint pain is acute or chronic. How can we differentiate? We have a duration which is 6 weeks. If the duration of joint pain is less than 6 weeks, so this is called acute. If it is more than 6 weeks, this is called chronic. Examples of acute, we will think about infectious arthritis. This is the first differential diagnosis. Also, we will think about acute crystal-induced arthritis. The most common type of crystal-induced arthritis, of course, is the gouty arthritis. Also, we may think that this is trauma, so I have to ask the patient if there is any history of trauma to the joint involved, and also the post-infectious or reactive arthritis. As regards the chronic, all systemic autoimmune diseases can lead to chronic arthritis, like rheumatoid arthritis, seronegative spondyloarthropathy, also systemic lupus, and also the degenerative joint disorder like the osteoarthritis. The third question, whether the problem in the joint is inflammatory or non-inflammatory. Now we are proceeding to the joint involvement. If the patient is having articular involvement, so I want to ask if it is acute or chronic, then if it is arthritis or arthralgia. How we can differentiate by many, we have many differences. The morning stiffness can occur with both inflammatory and non-inflammatory. However, in inflammatory arthritis, it's prolonged. It will be more than 1 hour. However, in non-inflammatory arthritis, it is less than half an hour. As we can see in osteoarthritis, there is something called gelling phenomena. When the patient is sitting or resting, when you start to move, there will be some stiffness, but it will be for a few minutes. It is not more than half an hour. However, in case of rheumatoid arthritis or inflammatory arthritis, the stiffness is prolonged. It is typically more than 1 hour. Also, the systemic manifestations like the fatigue and fever, weight loss, lymphadenopathy are more with inflammatory arthritis. However, we cannot see this with non-inflammatory joint involvement. Also, we can find that the patient with inflammatory arthritis will have morning stiffness, and when the patient is early in the morning, he have maximum pain and all his joints are stiff. However, while the patient is trying to do some activities, the joint pain will be relieved gradually. So the activity slightly improve the inflammatory arthritis. However, it worsens the non-inflammatory joint involvement, like the mechanical low back pain, like the osteoarthritis. It will improve with it will increase with standing, with walking, and the reverse as regard the rest. The rest will improve the non-inflammatory joint involvement. When the patient is resting, he will be improved. However, the rest will worsen the inflammatory arthritis, as the rest will cause accumulation of the inflammatory cytokines at the joints, leading to more pain. However, with the movement, these inflammatory cytokines are relieved from the joint, so there is some improvement in the joint pain. Also, as regards the inflammatory markers like the ESR and CRP, it will be positive inflammatory arthritis. However, it will be negative in case of non-inflammatory joint involvement. Corticosteroids typically will improve the inflammatory arthritis in most conditions. However, it is not very effective in case of non-inflammatory arthritis. Examples of inflammatory arthritis are the rheumatoid arthritis, seronegative spondyloarthropathy, reactive arthritis, systemic rheumatic disease like the systemic lupus, crystal arthritis like the gout, infectious. However, the non-inflammatory, the most important example is the osteoarthritis, the traumatic, the osteonecrosis, the neuropathic, metabolic, endocrinal. This image showing the difference between inflammatory and non-inflammatory arthritis. This is the normal joint structure, as we mentioned before. In case of inflammatory arthritis, we can find that there is inflammation in the synovium, which lead to exudation into the synovial fluid, which lead to effusion. Sometimes synovial proliferation can be found here inside the joint cavity. This chronic inflammation will lead to erosions, bony erosions, which is responsible for the destruction which will occur in the case of inflammatory arthritis. So this inflammation will lead to the swollen, red, hot, tender joint, the cardinal signs of joint inflammation that we mentioned in the next slide, inshallah. However, in case of osteoarthritis, we can find that there is no inflammation in the joint. In typical cases, there is no inflammation of the joint. There is degeneration. This is the articular cartilage, which is present in normal joint. We can find that the thickness of the articular cartilage decreased in case of osteoarthritis, which lead to some sort of friction between bones and lead to new bone formation, which will cause the friction and pain in case of osteoarthritis. However, there is no inflammation, so typically there is no signs, cardinal signs of inflammation. So what are the cardinal signs of joint inflammation? This is the redness, as we can find here. The joint is, skin overlying the joint is red. The hotness, as we can find in the image, we can test the hotness by using the dorsal aspect of the hand. We should compare both sides with each other. We should compare the skin overlying the joint with other parts of the skin. We have also the limitation of joint movement. We should, in case if there is limitation of joint movement, this is also a sign of inflammation. The tenderness, which can be done with examination. I can detect the tenderness when I am examining the patient, and also the swelling. If I find that the joint is swollen, this is also a sign of inflammation. So if the patient is having joint pain plus one or more of these cardinal signs of inflammation, this means that this patient is having arthritis. If the patient is having just joint pain with no cardinal signs of inflammation, this is arthralgia, non-inflammatory joint involvement. The fourth question is the number of joints involvement. If you have one joint involved, this is called monoarthritis. If we have 2, 3, or 4 joints, this is called oligoarthritis. If we have 5 or more joints, this is called polyarthritis. Each cause or each number of joints have certain important differential diagnosis. We will start by monoarthritis, which means that the patient having single joint inflamed. It's either acute or chronic. In case of acute monoarthritis, we have 3 important differential diagnoses that I should think before thinking about other causes. We have to think about the septic arthritis, that there is a bacterial infection inside the joint. I have to think about acute crystal-induced arthritis, and the most common cause is the gouty arthritis. And also I should ask about trauma. I should think about trauma or hemoarthrosis. So I should ask the patient if there is any history of trauma to this joint, if the patient is taking any anticoagulant that may cause may lead to hemoarthrosis, if there is toxicity or overdose from this medication, or if the patient is having a problem with coagulation disorder like the hemophilia, may present with also hemoarthrosis. As regards chronic monoarthritis, we will think about also infection, crystal, spondyloarthropathy may present with monoarthritis, osteoarthritis, or osteonecrosis, or monoarticular presentation of polyarticular disease like rheumatoid and systemic lupus, but this is not common or not typical also. As regards oligoarthritis, oligoarthritis means that the patient having 2, 3, or 4 joints involved. If it is Acute presentation, still I will think about infection or post-infectious causes like reactive arthritis, or maybe acute presentation of spondyloarthritis. The most important or the first differential diagnosis of oligoarthritis is spondyloarthropathy. In case of chronic as it is systemic disorder, so it is mostly a chronic systemic disorder, so it is mostly presented with chronic oligoarthritis. Also, I may think about osteoarthritis if it is presented with arthritis also, and also the oligoarticular presentation of polyarticular disease, but this is not typical. As regards polyarthritis, chronic polyarthritis is the first differential diagnosis of chronic polyarthritis is rheumatoid arthritis, systemic autoimmune disease like rheumatoid arthritis, systemic lupus erythematosus, spondyloarthropathy, especially the psoriatic arthritis, which is mostly present with chronic polyarthritis, and also the osteoarthritis and chronic gout. The chronic gout has polyarticular presentation, and its presentation is very maybe misdiagnosed or difficult to be differentiated from rheumatoid if the history is not taken from the patient properly. As regards the acute polyarthritis, the first differential diagnosis is viral infection. Viral infection may present with polyarthritis, sometimes maybe rheumatoid-like, but this patient will improve even without taking treatment. This is what's called self-limiting condition that will improve even without treatment. Also, some cases of rheumatoid and systemic lupus may have acute presentation that lead to acute polyarthritis, but this is not the typical for lupus and rheumatoid arthritis. Now we will go to the fifth question. The fifth question is the distribution of the joint involvement. What's the meaning of distribution? The distribution may be symmetrical. We will explain this in the next slide, inshallah. Or asymmetrical, symmetrical like lupus and rheumatoid, asymmetrical like the seronegative. It may be peripheral or axial. Peripheral like rheumatoid and systemic lupus, axial like seronegative spondyloarthropathy, maybe small joints like rheumatoid and systemic lupus, or large like seronegative spondyloarthropathy. And this image showing the difference between symmetrical and asymmetrical arthritis. In case of symmetrical arthritis, as we can see in this image, we can find that joint involvement over the right side is similar to over the left side. They have the same pattern of joint involvement, so this is called symmetrical arthritis. Also in this image, we have different pattern from this, but we can find that the joint involvement over the right side is similar to over the left side. This pattern is in case of rheumatoid arthritis. We will talk about this in the next slide, inshallah. However, in the case of asymmetrical arthritis, we can find that joint involvement over one side is different from the other side. Also here, joint involvement in one side different from other side. So this is called asymmetrical arthritis. What about peripheral and axial? Axial joints are the joints of the spine, like the cervical, the dorsal, the lumbosacral, and the sacroiliac joint. These all are called axial joints. However, all other joints like shoulder, elbow, wrist, small joints of the hand, hip, knees, and joints of the foot, all these are peripheral joints. As regards small or large joints, you can find that joints of the hand and feet are small joints, except the ankle. The ankle is large joint. The MTB is small joint. The DIBs, BIBs, MCBs, wrist joints. MTB is the metatarsalophalangeal joint. MCB is the metacarpophalangeal joint. BIB and DIB is proximal interphalangeal joint and distal interphalangeal joint. And also the wrist joint, all these are small joints. However, the shoulder, the elbow, the hip, knee, and ankle, all these are large joints. Finally, we should ask the patient about extra-articular manifestations. Extra-articular manifestations are very important and may be a very important clue for the diagnosis of the case. In case of rheumatoid arthritis, I may find subcutaneous nodules, which are called rheumatoid nodules. I may find dry eye and dry mouth, and this can occur with what's called secondary Sjogren syndrome. Sjogren syndrome is an autoimmune disease which affects the exocrine glands. It may occur primary without underlying autoimmune disease. However, it's commonly present secondary to rheumatoid arthritis. In case of systemic lupus, the extra-articular manifestations are more important than the joint involvement because it is a very important and very common and more common than the joint involvement. We may find mallar rash as you can see in this image, which is erythematous rash affecting the butterfly area and sparing the nasolabial fold. You may find hair loss, you may find oral ulcers, and also the systemic symptoms like the joint involvement. If I find the kidney involvement, is I find if I found a patient with kidney involvement with together with joint involvement and arthritis, one of the most important differential diagnosis is the systemic lupus. Also, the neuropsychiatric involvement, the fever, the cardiac involvement, all these can occur with systemic lupus. In case of gout, if the acute attack of gouty arthritis occur on top of chronic gout, I may find gouty tophi. The gouty tophi is the deposition of monosodium urate crystals in the subcutaneous tissue. In case of spondyloarthropathy, I may find anterior uveitis, which is one of the SPA features or extra-articular features of spondyloarthropathy. Also, the presence of psoriasis, skin psoriasis, and psoriatic nail, which is suggestive that this patient is having psoriatic arthritis. Now we will talk about the cardinal features of common rheumatological disorders that you will find in your daily practice. We will start by the rheumatoid arthritis. The musculoskeletal involvement in rheumatoid arthritis is articular. Joint involvement is typically chronic, and of course it's inflammatory. The number of joint involvement is polyarthritis. As regard the distribution, as we can find in this image, is symmetrical. In case of rheumatoid arthritis, the joints on one side will be similar to the other side. Small joints and large joints are affected, but the small joints are more common, and it's mainly peripheral. The axial involvement is not typical for rheumatoid, and the extra-articular, we may find rheumatoid nodules and dry eye and dry mouth. In case of systemic lupus, the musculoskeletal involvement may be articular or may be extra-articular. Myalgia also can occur in systemic lupus. The musculoskeletal involvement is, of course, chronic. In case of either it's inflammatory or non-inflammatory. In case of systemic lupus, it may be inflammatory or non-inflammatory. Non-inflammatory joint involvement in systemic lupus is more common than the inflammatory. However, if joint involvement of systemic lupus is inflammatory, it will be rheumatoid-like. It will be the same features as rheumatoid arthritis. It will be polyarticular, having the same distribution, bilateral, symmetrical, affecting small joints mainly and peripheral. And the systemic manifestations of systemic lupus is very important, like the mallar rash, hair loss, oral ulcer, and internal organ involvement, like lupus nephritis and neuropsychiatric involvement. In case of spondyloarthropathy, joint involvement may be articular or may be extra-articular, like the enthesitis, as we mentioned before. It's of course chronic. It's mostly inflammatory. It's typically the number of joints is oligoarticular in case of ankylosing and axial SPA. However, it may be polyarthritis in case of psoriatic arthritis. The joint distribution is typically asymmetrical in case of spondyloarthropathy. However, in psoriatic arthritis, it may be symmetrical. The axial involvement is the most typical and also the most one of the hallmarks for spondyloarthropathy. So the axial involvement is very common. And also the peripheral joint involvement can occur. And as regard extra-articular, we may find uveitis, IBD, and also the psoriatic skin lesions or psoriatic nail. In case of acute gout, the joint involvement is typically articular. It's of course acute. It's inflammatory. It's highly inflammatory. I will find in case of gouty arthritis all cardinal features of inflammation present in the patient joints. I will find the redness, hotness, limitation of movement. It's one of the highly inflammatory conditions. It's monoarthritis, and the most common site to be involved is the first metatarsalphalangeal joint, as we can see here. If it occurs on top of chronic gout, I may find the gouty tophi. By the way, gouty arthritis is one of the simple conditions that's common in the daily practice. You should know about how to diagnose. Also, osteoarthritis is a very common condition. The musculoskeletal complaint is usually articular, also usually chronic. Most of cases are non-inflammatory. maybe oligo or polyarthralgia. The joint involvement, as we can see here, is usually symmetrical, affecting mainly large and weight-bearing joints like the hips, the knees, and the lumbar and cervical spine. So there is also peripheral and axial involvement. We can find extra-articular features like the Heberden and Bouchard nodes. We can find here, these are the bony nodes which are present at the distal interphalangeal joint. This is called Heberden nodes, and the bony nodes or the bony swelling at the proximal interphalangeal joint. This is called Bouchard nodes. Now we have finished the clinical evaluation. Next, we will go to the laboratory evaluation. As regards the laboratory evaluation, we will start by the acute phase reactants like ESR and CRP. These are markers of inflammation that become high in case of inflammation. So it can differentiate between inflammatory and non-inflammatory arthritis. It will be high in case of inflammatory arthritis and normal in case of non-inflammatory arthritis. But you should know that these are markers of inflammation. So it will be elevated with any inflammation, even if there is infection in the body. So it is not very specific for this condition. As regards the basic investigations, also may be helpful, like the CBC. We can, as the hematological involvement is a common case of systemic lupus. So if there is mono, bi, or pancytopenia, I may think about systemic lupus. Also, the uric acid is important. High serum uric acid level is important for diagnosis of gouty arthritis. The autoantibodies are very important in case of rheumatoid arthritis. There is positive rheumatoid factor and anti-CCP. Rheumatoid factor is neither sensitive nor specific. However, anti-CCP is a specific autoantibody for diagnosis of rheumatoid arthritis. As regards systemic lupus, we have, of course, the anti-nuclear antibody and anti-double-strand DNA. Synovial fluid analysis also is very helpful whenever it is available. If there is available for aspiration, if there is synovial fluid available for easy aspiration, there is effusion in a certain joint, aspiration will be very helpful. It may be the most important clue for diagnosis of septic arthritis. If I find high white blood cell count in the synovial fluid together with positive synovial fluid culture, so this is diagnostic for septic arthritis. Also, it helps in diagnosis of gouty arthritis, as we will find urate crystals by polarized microscopy. This will be diagnostic for crystal arthropathy like gouty arthritis. Finally, we will go to the imaging. As regards the imaging, we can use the X-ray. The X-ray, in case of rheumatoid arthritis, we may use X-ray hands, which will show typical changes of rheumatoid arthritis, like the bony erosions, loss of joint space. As we can see here, that the bones, the carpal bones of the wrist, they are fused together. I cannot count these bones from each other. So there is a loss of joint space. I can find that there is erosions. The ends of the bone are irregular, or these are the erosions. I can find that the joint will appear as a black line between the bones. However, I cannot see this in this joint. This is called loss of joint space. Also, there is periarticular osteopenia, in which the density of the bone around the joint is decreased. The bone is the color of the bone in the X-ray is white. However, around the joint it's dark gray in color. This means that there is periarticular osteopenia. Also, the X-ray over the knee may be helpful in diagnosis of osteoarthritis. We will find narrowing of the joint space. We will find sclerosis of the bone margin, and also we may find osteophytes with our bony projections at the sides of the joint and the bony ends. Also, the MRI is very important in case of spondyloarthropathy, as we may do MRI over the sacroiliac joint and found the sacroiliitis, which is diagnostic for spondyloarthropathy. Finally, we will talk about one of the common complaints, which is generalized musculoskeletal pain. Some patients come to the rheumatology clinic, or maybe to the outpatient clinic of the GP or the GP clinic. He have generalized musculoskeletal pain. He have pain all over his body. If you ask him in your joints or in your muscles, he will say all over the body. In all my bones are hurting me. So the differential diagnosis of this may be osteomalacia and vitamin D deficiency, and this is very common, especially for females. Joint hypermobility may be for children. The fibromyalgia, the polymyalgia rheumatica. Polymyalgia rheumatica is some inflammatory disorder, which is the patient. It usually occur in elderly females, and it will accompanied with signs of inflammation, i.e., SARS, CRB, and maybe accompanied by fever. Also, the connective tissue diseases like the systemic lupus, the lupus myalgia, as we mentioned before, or polymyositis, and also the thyroid disorder. So at first, we should exclude that this musculoskeletal pain is not related to something dangerous like the malignancy if there is no systemic manifestation, no loss of weight. So this can exclude the dangerous differential diagnosis like the bone mets or something like this. If there is no fever, ESR and CRB are normal, so I can exclude the polymyalgia rheumatica and also immune connective tissue diseases. I have to do for the patient thyroid function. Also, I have to do vitamin D level. If there is vitamin D deficiency, if it is corrected, the patient will improve. Finally, I want you to know something about the fibromyalgia, which have become common in common presentation in rheumatology and the GP clinics because due to the stressful life, because it's related to the stress, the patient will present with generalized pain affecting mainly the trunk, back, and neck. The patient will have accompanying features like the fatigue, poor concentration, focal areas of hyperalgesia, these areas having these blue dots. These areas will be tender in this patient. Upon examining this patient, these areas will be tender. Also, commonly, this patient having sleep disturbance and medical and unexplained symptoms like the IBS, tension headache, and irritable bladder. It's important to know that fibromyalgia is diagnosed of exclusion. I have to exclude other causes, as we mentioned before. If there is no causes and patient having these typical features, so this patient is most probably having fibromyalgia. This was a rapid approach for patient with joint pain. I hope it will be beneficial for you in your practice, and thank you.